welcome to today's channel. This is Health Focus. My name is Amy. Last time we were having an orthopedic technologist and he told us about trauma issues. Today we are going to move a little moment away from trauma and look at the deformities they work on. Have you ever seen a child who has bowed feet? Or have you ever seen a child who has knocked knees? Have you ever seen a child with a flat foot? You should not have that child at home. We have people who've gone to school, we have professionals in orthopedic units who can manage those diseases. And Mark here, who we had last time, our guest, is going to tell us more on how they manage these issues so that your child can have a fulfilled life. Thank you and welcome. Karibu, Mark.
Thank you so much.
So, again, in continuation from what we had last time,
Yes.
we're moving away from trauma and we're moving to the area that we're managing issues that are congenital. That means patients have been born with that condition, children. And when a child has been found to have a deformity, kindly elaborate the kind of deformities you manage as orthopedic technologists.
Okay. Thank you so much. For us as orthopedic technologists, most of the time there are very many deformities that we come through on a daily basis, but majorly the deformities that we have in the orthopedic section, we have now the club foot. Club foot is just a name, but our medical term is called CTEV, which in full it means congenital talipes equinovarus. That means that our child is born when the foot is curved inwards. Yes. Now that one is managed at the orthopedic unit, where now the child is done serial casting through the Ponseti method on a weekly basis for around 6 weeks. After that, for maintenance, we do a slight tenotomy, where now we involve our surgical team. They help us in releasing now the Achilles tendon. After that, we do now the bracing, where now the child can use the braces up to 5 years. That is the common type of deformity that we have in children. The other one now, after they're born and...
No, before we go to the other deformity,
yes.
This talipes, club foot,
Yes.
It's a series of treatment up to 5 years.
Yes.
And at what stage does the child walk properly?
Yes.
Is it at 5 years?
No, even at 1 year. Because after correcting, we correct within 2 months. The child has, the foot is corrected. Now the thing is just maintaining the foot so that, because most of the time it's recurrent. When you leave it without using the braces, it recurs.
Oh.
Yes.
Why does it recur?
It recurs because most of the time it involves the muscles. And most of the time when the muscles now are contract, it moves now the bone, because the bones are not yet formed fully, so it moves back to its original position.
What could be the reason as to why a child will have club foot, or what will a mother do to prevent it?
Most of the time, up to now, it's still unknown.
Okay.
Yes, still it's unknown. It's an idiopathic. It's not yet known. It was discovered in the 18th centuries. Up to now, there's no cause.
Known cause.
There is no known cause. So it's just idiopathic. It's a known cause.
So even after correcting after 1 year, if
Yes.
the child does not continue with the clinics, it can fall back.
Yes, it can recur. And when it recurs now, mostly after 1 year, it's always very difficult to manage it. And that one now will go back to the surgical team that now help now in the realignment of the bone.
Is it possible to realign a child after 10 years?
It's still possible.
An adult?
An adult still it's possible, though it will still remain with part of the disability, but now it will be corrective, it will be able to step well, though with the difficulties at adulthood.
Okay.
Yes.
All right, thank you. The next deformity?
The next deformity we have at the knee joint, where we have, it's called, in our layman's language, it's called knocked knee or bow-legged, which is genovarus and genovalgus. So that one, most of the time, you'll notice it when the child now has started to walk at 1 year and to 2 years. That's when now you notice that your child now, when he's walking, the leg appears bowed or they appear knocked. So with that one, most of the time, we always give the patient, the children time up to 18 months. That is 1.5 years. After we notice that is still persistent, is when now we do bracing, and most of the time we do orthosis. It's called orthosis that helps now in correcting now the deformity.
Whereby they wear a shoe?
No, it's called an orthosis because it's moving from the thigh to the foot, and it corrects also the knee.
Okay.
Yeah, on that process. So the child will be using it during the day and also at night.
They sleep, they walk in it, they stay in it, they sleep in it.
Yes.
For how long?
For around 3 months. And after 3 months, we do a review. And then after we do a review, when we see that most of the time it has corrected, we move on and give them now the foot orthosis, where we can give them inner soles that can help now to maintain the correction.
Okay, can that kind of deformity be corrected at adulthood?
It can be corrected, but surgically.
Surgically, yes, now?
Immediately after 5 to 7 years. Now after post 7 years, we do surgical, where now we do osteotomy with pinning to correct now the deformity.
Wow.
Yes.
But it's correctable?
Yes, it's correctable when you realize and the parent has noticed with the child when he or she is still small.
Okay. And the last deformity is which one?
It's pace planners. That one we call it flat foot.
The flat foot.
And most of the time you'll find it in adults, in children, and it's correctable. So the bone formation for the arch is always done at the age of 1 to 5 years.
What to a layman's language, what's an arch?
The arch from a layman's language is this arch is just an increased
gap. We call
gap.
It that there
Yes,
must be a gap.
Gap between now the forefoot and the hind foot.
Okay.
You'll find a gap. That one is now the arch.
Is there a problem when you don't have it?
It is a very big problem, because most of the time you'll find that when you walk for a long distance, you'll find that your ankle is paining, or the calf muscle to the knee. You cannot do most of the hikes, because when you do the hikes, you'll find that it's praining and straining. Mm-hmm. So that's why after doing maybe a long walk, you'll find that someone has pain, and he or she cannot walk past that.
Wow.
So it's very important for someone to have that arch.
I don't think the population will have that knowledge, but at least thank God you've explained it. So how is that corrected?
Most of the time they fabricate something called an arch support. It's a special type of inner sole that is used now for most of the children, where they always do it inside the shoe, and it does correct.
How long again should you use it?
For 4 months. After 4 months, we do a review, and then when we realize that it's still persistent, now you can go for an AFO. There's something called, it's an ankle foot orthosis that helps now to stabilize both the ankle and the foot.
Wow. So again, the question is, can an adult have their flat foot corrected?
For an adult, it's not corrected, but it's always maintained. And for maintenance, you just use an arch support. That one helps now to elevate the bones that are at the arch, the navicular, the talar bones, so that when you are walking, they don't collapse. And that one helps now you can walk for a long distance, but it won't correct. It will just be there to maintain the arch.
Wow. For more information, somebody should just get an orthopedic technologist to have their consultation done and management done. One last question. What's the difference between a trauma technologist and an orthopedic technologist?
Yes, the difference is an orthopedic technologist is a person who helps now in fabrication of prosthesis and orthosis. A prosthesis where now after surgery has been done or an amputation, when you have a person who has been amputated, they help them now get an artificial limb. When people who have weak muscles of the ankle, of the thigh, they help now in fabrication the orthosis that helps that helps them now in supporting the muscles.
Their role is mostly making prosthesis.
Yes, prosthesis and orthosis.
That's their role.
Yes,
fully.
that is their major role.
And the trauma orthopedic technologies is to deal with the trauma.
Yes, and they are mostly involved in fracture managements and reductions of shoulders, everything that entails trauma.
And deformities.
Yes.
Do orthopedic technologists also manage congenital deformities?
Yes, they do.
So your role is intertwined?
Yeah, they are intertwined.
But most of their role will be making prosthesis, or they also
yes,
manage?
And orthoses, and they also help now in fracture management. Most of the time they also do. Because most of the time they help also in the Ponseti methods of clubfoot. They're also engaged.
Okay. So somebody will ask, if I want to do one of them, they'll want to know the difference as clear as it can be.
Yes.
So can me as an orthopedic technologist also manage everything apart from the fractures when I compare with orthopedic technologist and trauma orthopedic technologist?
Yes, for an orthopedic technologist, you can do everything. You can also manage the fracture. Okay. And most of the time, for a trauma technologist, you'll be involved mostly in the fracture management specifically.
Okay.
Yes.
You've heard it for yourself. You've heard how congenital malformations can be managed. If you want to know more about this career and more about this, comment down below. If you like this kind of content, share, like, and leave a comment down below. If you want to know more about Mark as an orthopedic technologist, also comment down below or send an email and it will be responded as soon as possible. Thank you so very much. Let's meet again when we're talking about another career. Who knows, maybe an orthopedic technologist, maybe a pharmacist. Let's meet next time. Good day.